Right, thank you. So, welcome to Japan. So, I appreciate the great opportunity to present this lecture. No COI. So, my subspecialty is hip surgery, and I usually perform the total hip arthroplasty and the pelvic osteotomy. However, in the outpatient clinic, it's sometimes difficult to decide whether the pain really comes from the hip. So about 40 years ago, the concept of hip spine syndrome was proposed because the sacroiliac joint lies between the hip and the spine. We believed that it should also be involved as an adjacent joint. Therefore, last year, we reported the concept of the hip SIJ spine syndrome. In this patient with osteonecrosis of the femoral head, she had mild scoliosis, but no spondylolisthesis and no irregularity of the SIJ. Osteonecrosis usually progresses quickly from onset to surgery, and pelvic morphology is usually normal. In contrast, this case of the hip osteoarthritis secondary to development dysplasia of the hip shows scoliosis, S3 for spondylolisthesis, and SIJ irregularity. It was suggested that this patient suspected of having hip spine syndrome present with SIJ degeneration. We found that SIJ degeneration was significantly more frequent in patients with hip OA than in those with ON. Furthermore, in the DDH-related hip OA group, the time to THA was longer, pelvic tilt and scoliosis were more common than and SIJ irregularity was more frequent. This suggests that DDH morphology or long-term stress due to hip dysplasia may lead to SIJ degeneration. Dr. Toyohara analyzed of change in the stress of the SIJ and the posterior SIJ ligament before and after periacetabular osteotomy in 4 cases. I did. Only the acetabular dysplasia was corrected. All other conditions maintained unchanged. The result shows that the correction of the acetabulum reduced the stress of SIJ. This means that preoperative dysplasia hip showed increased stress on the SIJ, and acetabular dysplasia was found to create an environment prone to SID disorder. These studies suggest that OA secondary to DDH may be associated with greater SID degeneration than osteonecrosis. The morphology of DDH imposed increased stress on the SIJ and the posterior ligament, and long-term overload may contribute to SIJ degeneration. Therefore, OA secondary to DDH appears to be a condition likely to develop into hip SIJ syndrome. Inward wing pelvis may especially cause shear stress on the SIJ. It is likely to develop SID disorder. Indeed, 50% of SPO, PAO patients had a SI score of 4 point more higher. I'll show you a clinical case. This 70-year-old girl had bilateral groin pain and low back pain since age 12. She was referred to me because of DDH. That's a sound? No? Sorry. Yeah, I need a sound. I'm sorry, the sound is very important, but okay. So she had bilateral groin pain and side pain, and she cannot work without cane. And her lumbar MRI at the previous hospital is normal, and SRL are very tight. And her SIJ score, according to Kurosawa, was 7 point. Both sides, one finger test positive. As a first visit, she refused SIJ injection, so I performed my pelvic mobilization technique. So gradually, her leg is opened slightly. So the point of this technique is slightly rotated, and after that, her straight leg raising and improved immediately. And both also performed mobilization on the opposite side. The same pain will decrease. And the pelvic belt support, her symptom was relieved. Okay, after repeated mobilization, she was able to walk without cane. 3 months after first coming, she can without cane. And her pain has subsided during 2 weeks and present repeated program pelvic mobilization. She can walk. Okay. So 10 months later, her true hip pain worsened, and I performed a spherical pelvis osteotomy. She recovered well and could go abroad for language study. Several reports have shown that patients undergoing THA have significantly more SIJ narrowing than the vacuum phenomenon compared with controls. This suggests the hip OA affects the adjacent SIJ. The influence of sacroiliac joint fusion on hip function has been reported. It has been reported that SIJ fusion significantly increased the risk of the hip OA progression with an odds ratio 7.1 and increased the risk of THA dislocation by 2 times. And also long spinal fusion of more than 7 levels accelerate hip OA progression and take together the hip and the SIJ influence each other. Here is another interesting case. This 76-year-old female had a bilateral developmental dislocation of the hip and never loaded the hip joint in her lifetime. She supports her weight with gluteal muscles instead. Does she have degenerative change in the SIJ? What do you think? Surprisingly, her SIJ showed no degeneration. This suggests that hip pathology may cause SIJ degeneration more strongly than spinal disease. The Kurosawa's SIJ score is well known and very useful. This score involved growing pain as 2 points, but total 9 points. Dr. Kurosawa divided the SIJ into 4 zones and performed injection. In all cases, SIJ block reduced growing pain by more than 70%. Although the cause remains unknown, it was being proven to be a referred pain. And Dr. Murakami reported that the injection into the posterior ligament of the SIJ have a similar effect in many cases. So in my practice, we also inject mainly into tenderness point in the posterior ligament. In my daily practice, I often encounter cases in which I need to distinguish whether the groin pain originated from the hip joint from the SIJ. This 63-year-old woman was referred to THA due to advanced stage OA. She presented that groin and the side pain and hip contracture, especially the extension. And but she has also low back pain around the PSIS. So I performed the injection as a tenderness point around the PSIS. After the injection, immediately her hip extension and arm improved, as you can see, and her pain decreased. Without any hip joint injection, she achieved improvement in hip arm and pain relief, and went home without scheduling THA. So why PSIS injection improved hip arm and the muscle tension is under investigation now. We also investigated change in hip abduction external rotation angle, pre and post pelvic mobilization. In 17 limbs, average hip abduction with external rotation angle improved by average 21 degrees. And also 88% reported more than 50% pain relief. And also SLR and the leg length also improved. Just only the pelvic mobilization. Also the mechanism is unclear, but it's fact the relieving SIJ hypertonicity reduced joint and muscle tension. A case of 44-year-old woman with DDH and labral tear. An impingement sign was present in the hip joint pre-operatively. MRI showed labral tear of the right hip joint. 80% improvement of the hip joint pain was achieved by hip joint blocks, so SPO was performed. Also, the impingement sign initially improved after surgery, but after surgery, 1.5 years, she exhibits a recurrence, the hip joint impingement sign. So it's a no sound, but that face is so that pain. You can see. The other side, also impingement sign is a positive. Okay. So her SIJ score is 9 point. I performed the injection, the posterior ligament of the SIJ, the both sides. As a result, her impingement sign is disappeared. This suggests that SIJ block or pelvic mobilization can relax periarticular muscles, allows the femoral head to move down low and reduce labral impingement. Okay, so take-home message. SIJ degeneration are common in hip patients due to joint adjacency. Groin pain is common in both hip and SIJ disorders requiring different diagnosis. SIJ treatment can relieve groin pain, knee pain, and leg numbness in some cases. There are cases in which SIJ disorder lead to relaxation of lower limb muscle tension, resulting in the pain relief. Thank you.
I think we'll build in a couple minutes for questions. Any questions for Professor Kaneuji? I have one question. On the case you showed where your patient had clear hip arthritis and back pain, you did the injection into the PSIS extraarticular region, completely restored her hip motion. Do you have follow-up from her?
Yes.
Did she come back?
Yeah, one year after this, so the osteoarthritis progress. So terminal stage. So I do the THA already did, but 1 year her pain relieved. So during the 1 year, I checked it 2 times, but it's decrease.
My practice with that particular patient, I was surprised to see that. I think it's phenomenal, but my practice has shifted where if I see that patient in my clinic with very clear hip disease and SI joint disease, I usually will take them to surgery and do a hip replacement with complete resolution of the SI joint pain. And has that been your experience in some of those patients as well?
Yes, but the terminal stage away, I do that every time. Yes, THA. Yeah. But some patients, so it's a combined pain. So I try to that injection or some other treatment first. So yes.
So thank you for the lecture. So I have a question. So what kind of injection did you do in the PSIS? So it's a local anesthesia or just a serum or?
Yeah, no, local anesthesia.
So lidocaine, 1% lidocaine.
Yes,
10 cc.
Yeah, 10 cc is so it's only diagnosis. 5 cc is okay, but as a treatment, so I more injection, little bit some area. So 10 cc.
Thank you very much. So in my experience, sometimes I use a serum, just serum, 10 cc, and then after injection on PSIS or in ligament, so the patient pain disappears. So
oh, really?
What? Yeah. What? So how do you think about that?
Yeah, I'm not sure, but yeah, it's a very interesting.
Okay.
So I tried.
Thank you very much.